Yes, Dr. Tarek.
It's my pleasure to share with you today some of the experience in epidemiology of iron deficiency anemia, particularly with the focus of the prevalence of iron deficiency anemia in Saudi Arabia. And I will end my talk by going through the recently published Saudi clinical pathway for iron deficiency anemia. I will be going through some of the epidemiology of iron deficiency anemia in general, then a focus of the prevalence in Arab countries, then change to the area of Saudi Arabia where the some of the work done on the prevalence of iron deficiency anemia, and then I will end my talk by highlights on the recently published KSA clinical pathway. All of us knows that iron deficiency and iron deficiency anemia remains one of the most severe and important nutritional deficiencies in the world. It affects every age and it impairs many organs. It can impair the cognitive development of children, starting from infancy and adolescence. It affects the immune system and can damage the immune system and decrease the immunity, is associated with increased morbidity rates and affect the quality of life. One of the important areas where it hit by iron deficiency is the hair and skin, and that's particularly for females are important and an issue that may affect the quality of life. During pregnancy, iron deficiency anemia is associated with multiple adverse outcomes, including the morbidity that can happen during delivery with a post-delivery hemorrhage. Programs of supplementation for pregnant women had started.
Dr. Tarek, السلايدز حقتك ما بتتحرك.
It's not moving. Sorry.
It's not moving.
Not moving still? Yeah, 1 minute.
Still.
Is it moving now?
Yes.
Okay. So sorry. I'll go back to this second. Yes, here. Programs of supplementation for pregnant women underway in 90 of 112 countries has been reported by WHO, and 30% impairment of physical worth had been reported again by WHO. So if we would like to define the iron deficiency anemia or iron deficiency by itself, there were a lot of controversies when to call it iron deficiency. Many cutoff had been tested to be sensitive and specific for defining iron deficiency or iron deficiency anemia. And lastly, the WHO in its guidelines, which was started in late 2000, 2008 or 9, they looked at 3 levels, the 12, 15, and 30 nanogram for ferritin, and they defined the iron deficiency if the person has lower level of ferritin, be it 12, 15, or 30 nanogram in absence of anemia. To call it iron deficiency anemia, you need to have the iron deficiency plus low hemoglobin, which has been defined as 12 gram per deciliters for female and less than 13 gram for males. If we go through the epidemiology of iron deficiency worldwide, we can look at, for example, in USA, the prevalence of iron deficiency anemia was greatest among toddlers between 1 and 2, 7%, and adolescents reaching up to 16%. The prevalence was higher among non-Hispanic, Black, and Mexican families. Again, it's been affected by the socioeconomic status of these people. In Europe, the prevalence of iron deficiency again varies from 7 to 18%. and up to 36% in some of the reports among toddlers and adolescents. The prevalence of iron was also varies between 8 to 10% in toddlers and adolescents in another report. In India, where the socioeconomy is much lower than Europe and in America, the prevalence of iron deficiency anemia among medical students was reported to be 32%, of whom 44 were males and 20 were females, male. There is, again, if we look at some of the oldest publication about distribution of the iron deficiency among different ethnicity, even within the same country as in USA, you would find that there is a great difference between these based on the ethnic background. For example, you can see that in Hispanics, up to 15% or 20% can be seen, while in non-Hispanics, it's 2 to 3%. If we move to the Arab world, frankly, not too many publications being done or epidemiological studies being done in the Arab population, and most of the reports coming from single centers or small cohorts. But that would give or shed a light on the frequency and prevalence of this of iron deficiency or iron deficiency anemia among Arab population. If we start with United Arab Emirates, there is a report by Wafa et al. Of around 29% of patients presented to their institute with iron deficiency anemia. In Syria, Lama et al. Had reported among infant, 135 infant, they had 72 of them, they had iron deficiency, and 55% they had iron deficiency anemia. In Yemen, again, there was among school students, they reported 30.4% with iron deficiency anemia, and only 5.2 they had no symptoms or non-iron deficiency anemia. In Oman, the prevalence of iron deficiency anemia was reported as by Salam al-Kindi, again from institution, as 26% and 38% they had iron deficiency without anemia, and with predominance as expected in females. In Morocco, Ikari et al. Had reported iron deficiency anemia in 6.2%. And just to remind you again, all these studies are hospital-based, not epidemiological, and it has its own bias for reporting. Saudi Arabia is a large country, and it consists of many regions. It's spread over 2.5 million kilometers, and it has 4 major or 5 major areas: the north, south, east, west, and central. Again, the reports from Saudi Arabia mainly coming from small institutes, from hospital-based or universities, with only one large study which was conducted recently in the last few years, and we will talk about it in more detail. The prevalence of iron deficiency anemia had been reported among university students by Al-Hassan et al. From the west side to be 23.9% as in general. And the Kari et al. Had reported the prevalence of mild anemia, which been defined as 10 to 11, and moderate anemia 7 to 10, and severe less than 10 in 45, 49, and 6%, without differentiating between what is the type of anemia. The prevalence of iron deficiency anemia, again, been reported in another study by Ultra et al. And showed iron deficiency anemia and iron deficiency both constitute around 23%. In the latest study, which I will focus more in, which was a well-designed study, epidemiological study, we had reported the prevalence of iron deficiency of 28.6% and iron deficiency anemia 10.7% respectively. This study, which was part of the national survey for prevalence of bleeding disorder in Saudi Arabia, which was supported by a grant from King Abdulaziz City for Technology, and it was what's done over 4 to 5 years, where it involved of the country. 1,192 students had been involved in this study, all of them being recruited and randomly by first come first questioned. All of them had gone through a questionnaire, then sample collection and sample analysis. If we look at the results of the survey, we can see that from the survey itself, which involved few questions about the knowledge of the students or the knowledge of the participants about the anemia, you can see that only 14.4% they have a knowledge that they have anemia, and most of them they know that they have iron deficiency anemia, but the portion of knowledge is quite small, represent only around 11% of the participants. Other disorders, and that's again something we found during the survey, but I will not focus on it. The presence of thalassemia and other causes of anemia were detected during that survey. We had looked at the survey with applying the 3 cutoff values for the definition of iron deficiency and iron deficiency anemia, and the groups had been divided to 3 groups. Group A, where ferritin is normal and hemoglobin is normal, so these are a normal persons, and from the cohort 61.2% were completely normal. They don't have any of the criteria for iron deficiency or iron deficiency anemia. The group B, which has a low ferritin, and that being also looked at by 3 levels, the 15, the 12, and the 30. As I told you, the controversy that still ongoing among the WHO and the definition to which cutoff is the most sensitive. So we had the chance to look at these 3 levels, and I'll show you the difference between the 3. And we looked at the thalassemia and sickle cell anemia at the same time. And as you can see here in the second graph, the level of ferritin less than 12 could detect most of the patient. Yet there are a portion of the patient, if you don't or if you do only the less than 12, you will miss mild cases of iron deficiency anemia. And that's, again, I think in agreement with what finally WHO had alluded to use the cutoff less than 30 as the recommended cutoff to define iron deficiency anemia or iron deficiency. We had also looked at the differences between the prevalence of iron deficiency and iron deficiency anemia among different regions of the country, and we did not frankly found much difference. Most of the region, they have almost the same prevalence, around 11.5 or 9.8, but there were no much difference, and that's basically because the the country, if we look at the socio-economic status, it's been distributed among all regions. So all regions have the fair distribution of different socio-economic status. The conclusion from that study was looking at the looking at the prevalence of all the causes of iron deficiency anemia, and we could see that, as you can see, that the majority are the iron deficiency, while a small portion of the iron deficiency anemia. I'll move gear now to the second part of my talk, which is the guidelines and clinical pathway, which was an effort supported by the Saudi Society of Blood Disorders, and under the Saudi Council, Saudi Commission for Health Specialty, as one of the initiatives of the Saudi Commission for Health Specialty to improve the practice among practitioners in the country. And because of what I had just explained to you, of the high prevalence of anemia in general, and particularly of iron deficiency anemia, a group had been gathered to go through the medical literature, go through the evidence base, and apply their experience in the field of hematology to guide general practitioners as well as hematologists to what is the best way of diagnosing and managing this iron deficiency or iron deficiency anemia. The group was led by Dr. Uthman Ayoub, Firas Al-Freih, and there was a work done by Dr. Osama Khoja and Amal Al-Bihani, and it went through some of the review by reviewers, and finally it was approved and published on the website of the Saudi Commission in 2020. The guidelines had looked at the various parts of the diagnosis. It defines very well the levels as WHO had defined it, using the latest update in the WHO, which is the 30 as a cutoff for ferritin, and 130 gram per liter for men for the hemoglobin, and 120 for the women. They had elaborated on the clinical presentation and the symptoms of iron deficiency anemia, so that will be the first diagnostic tool before going through the management of the iron deficiency. They have provided an elaborated clinical pathway, but because of the sake of the time, I'll show you a couple of the slides from the guidelines, including the algorithm for diagnosis. And as you can see, they nicely had separated the different parts of the diagnostic tools, starting from evaluating the CBC and red blood cell parameters, and incorporating that with the morphology, and based on the MCV and the anemia level, they divided it to where to start with. To start with the iron, or to start with the B12, and then if you have a suspicion of iron deficiency, then you go through different areas of exploration, more the causes of iron deficiency anemia, not only to stop at defining the iron deficiency, as we all know that iron deficiency is not a disease by itself, it's a manifestation of something under that. And unless you identify the cause of iron deficiency anemia, the patient will have a chronic iron deficiency anemia that will not be resolved and will keep having more and more attacks of iron deficiency anemia. They also looked at the management of the iron deficiency anemia and they put it in a stepwise from the diagnosis to the monitoring of the iron deficiency based on the response of the patient to the initial management. They had also looked at the different types of managements and addressed the fear among a practitioner of using the parenteral iron. As we all know that it's a fear not only among patients but also among practitioners that parenteral iron is associated with a lot of risk and it should not be used, which is against all the recommendation, local recommendation and international recommendation. Parenteral iron is one of the tools. It needs to be used appropriately to result in elevation of the symptoms. And patient who is presenting with a low hemoglobin like 6 or 7, and that's frequently seen in practice, instead of going to rushing to the blood transfusion, I think the parenteral iron is a good tool for fast recovery of the hemoglobin, because the oral will not give that quick action as the parenteral supplement. The guidelines is quite extensive. I would like to recommend everybody to go through it. It has knowledge and also clinical experience. Before ending my talk, I would like just to highlight a few points. Iron deficiency and iron deficiency anemia are common. We could see that it's reaching up to 30% of the population. They may have or may suffer from the iron deficiency or iron deficiency anemia. It's a disease if we define it by symptoms and signs, but it's mainly a manifestation of an underlying disease. And unless we identify the disease, the cause of the iron deficiency, the patient will continue to suffer of the iron deficiency. And iron deficiency anemia is affecting the quality of life. The quality of life can be measured by many measures, and there are many works going on, including a work we are doing now among patients with iron deficiency to see how much the impact of iron deficiency anemia on their physical activity, on their self-acceptance, and particularly for females, on their the appearance and the hair and skin manifestation. We all know that early diagnosis and early management can dramatically improve the quality of life. The clinical pathways and guidelines are just a roadmap for practitioner. It's not to replacing the physician decision about what to choose and what to treat, but it's particularly for general practitioners who don't have much information for hematology, or for our young starting hematologists. This is a roadmap that will help them. With this, I would like to stop here and thank you for listening.